Thank you very much for having me.
First of all, congratulations on being elected as the next ARVO president.
Oh, thank you, David. I hope I do justice to it and help everyone enjoy their ARVO. So.
Excellent. Tell us a little bit about the priorities in terms of genetic testing and policies from a clinician's perspective.
So we're specifically speaking about genetic testing for age-related macular degeneration. This is something that has been going on for some time. We certainly are endorsing it for research, which is very important because we need to understand the pathways and perhaps target drugs that may be very important for treating macular degeneration. And we are far from finding at least a cure for geographic atrophy. Nice treatments for neovascular AMD, but still a lot more to learn. So we've learned a lot from those studies. But to do it clinically as a tool to help us understand whether we should treat with anti-VEGF therapy or with some form of vitamins or minerals, that probably is not yet to be done. We should not recommend that at this point. We don't have enough data to suggest that this is important. So the genetics of AMD is that complement factor H, which came out in 2005, is an important factor associated with macular degeneration, a very important genetic factor. And not far behind is ARMS2 or chromosome 10. That's very important as well. These two account for a huge amount of the genetic variance and association with macular degeneration. And that's been used as a test by a number of companies, and one in particular is very interested in helping patients choose whether certain components of the ARVO supplement is very important. And that is the ARVO supplement, which has been found to be helpful in reducing the risk of late AMD by as much as 25% in 5 years. That includes vitamin A, C, beta-carotene, zinc, and copper. The proponents have suggested that certain genotypes will be helped by taking just antioxidants alone or zinc alone. In some cases, they feel that zinc may in fact be harmful. So we've set out to look at this ourselves to do a very large evaluation. We took all the data we have with genetic data, people with categories 3s and 4s in AMD, in other words, people with intermediate AMD or advanced disease in one eye. We looked at their genetic information and see how there was any interaction between that and the genotype. In other words, did the genotype influence how one can respond to the ARVO supplement? And we found that in all genotypes that there was a good response. And we recommend only the combination of therapy in our large studies. It took us 5,000 patients and more than 6.5 years to prove that it's the combination that's the best. Antioxidants and zinc should be given together. We then also found a second group of participants who were not included in the original evaluation of this particular group, Dr. Carl O's group, and they did the original analysis. And we did the secondary analysis to duplicate whether we can find the same sort of findings. In other words, these are replication sample to see if we can get the same results. And we could not repeat them. And again, with that small sample, we found that with all genotypes, that there was a beneficial effect for the combination of antioxidants and zinc. So given that, we really feel that it's not time yet for us to do any genetic testing for AMD prior to any therapy. The data just isn't there at this point.
Patients are frequently taking polyvitamins from virtually every imaginable source. The vitamin supplementation in food, there's vitamins that are taken over the counter. How do you get a message out to people that there's a reason why we call them vitamins?
Right.
Because minimal is better than maximal.
Right. So the vitamins, when we did our original studies, we actually gave our patients a multivitamin of a certain type so we can standardize it. When we did our analysis, it made no difference. In other words, the multivitamin did not affect our course in macular degeneration. So we think it's very safe to combine a multivitamin like a Centrum, for example, that we've given in the past. And that's what we've given in both of our studies. But the vitamins we're recommending for the macular degeneration are rather high doses. You cannot eat that much in your diet. So those are high doses that we have proven in a randomized trial. So we feel very comfortable giving those because we found that mortality is not increased by this particular combination. We also found, in actual fact, patients who are taking the zinc in addition to the antioxidant actually have a slightly lower rate of mortality. It doesn't mean that we're saving patients, but in other words, it's safe enough for patients to take. So.
Now, just with regard to AREDS, were you actually doing urinalysis to verify the vitamins that were in the system?
We actually did serum levels. That was even better. So we took serum levels before and after and did it on a yearly basis to see. It was a measure of compliance, whether patients actually took the supplements, and they went up quite nicely, and it was a marked increase in those who were taking it. So you could actually measure the compliance quite well.
Excellent. Tell us a little bit about the work that's been presented. You've moderated a number of sessions, you've led a number of major sessions here at ARVO 2015. What are the most exciting areas to you that you've seen this year?
Well, I guess the meeting isn't over yet, so there are a lot of interesting things going on. There are new things being tried for geographic atrophy. I don't know if we have anything that's going to be ready to go, but we know there's a lot of endeavors, a lot of attempts to try and treat sort of the underlying disease of macular degeneration, which I think is very important. All sorts of trials that are going on, so I think that's very, very fascinating. The issue of whether anti-VEGF therapy may cause geographic atrophy with prolonged use is another interesting story that's being looked at. We don't have the answers for that either. It still needs a lot more work. So we have a lot to learn. But despite what we find, it's important for us to continue giving the anti-VEGF therapy, perhaps in a safer way, but certainly is very important because it has really remarkably reduced the risk of vision loss in patients who otherwise would really be legally blind. So we live in a very fortunate era right now.
Where do you see the progress in AMD research a year from now, 5 years from now, 10 years from now? Where would you like to see the trajectory?
I don't have a crystal ball, but certainly I would love to see ultimately is a primary prevention. If we can get it early on so people won't even go through those stages, we can prevent macular degeneration. But we're not there yet. There's going to be, I think, a great deal of work to be done. But perhaps even 5 or 10 years, we may get some clues as to where that might be. That would be very important.
How does gene therapy and stem cell therapy fit into this continuum?
Well, I think that's another important aspect that obviously is got a lot of attention, and things are going very rapidly in that area. Rapidly in quotes, because the regulatory aspects of this takes a long time. We're interested in doing that at the National Eye Institute as well as many other groups. That's very exciting. I don't know whether we'll have the answers in the next few years, but certainly is something worth looking at and might be very important in the future. But it would be nice if we could take something to prevent it before you get to the point where you have to replace the cell therapy. So.
Now we'll switch gears to talk about a patient message.
Yes.
Patients will be watching this particular segment. What can you tell them about where we are currently in terms of macular degeneration? Let me start with that question.
Okay, so I think where we're at with macular degeneration is that we're in a very good space in many cases. If you have neovascular or wet form of macular degeneration, there are good treatments which are injections into the eye with drugs that block certain factors that make these new blood vessels. So that's very important. And then we have choices of them, and we seem to have a good effect with vision improving, which is unheard of prior to these therapy. The dry form, unfortunately, still has no treatment, and we're looking for a therapy for that, and we're working very hard to do that. And certainly, the one thing we can do, and this has been proven by 2 studies, the age-related eye disease study, 1 and 2, AREDS 1 and AREDS 2, have proven that supplements, nutritional supplements with vitamin C, E and beta-carotene and zinc and copper have been very helpful. When we did the second study, we found that lutein and zeaxanthine, which are found in green leafy vegetables, are also very important in preventing macular degeneration. So now we've sort of reformulated that to a certain extent. The new AREDS 2 formulation hopefully will be something that patients will be able to have access to, and patients are told about this. It's very important. If you have an early form of macular degeneration, it is a very good thing to take. Given that information, we also know that diets are very important. So in our studies, looking at the nutrition, we know that people who eat lots of green leafy vegetables, fish twice a week really is very helpful in preventing vision loss. So you are what you eat. You should have a good diet replete with vegetables and fish twice a week, several times a day, or like several times a week of good vegetables, green leafy vegetables, and then the ARVO supplement that's really needed in terms of patients who already have macular degeneration, either advanced disease in one eye or have it in both eyes that are early enough stages that we can help prevent it.
Turning to genetic testing, patients have heard that everybody's getting tested for one or other genetic issue. What do you recommend that patients do with regard to genetic testing for macular degeneration?
I think if they're participating in some research, absolutely. It's wonderful to get that because those genetic tests can help us understand the cause of the disease and perhaps point to us some good treatments. But aside from that, I think it's too soon for us to recommend any sort of genetic testing for macular degeneration, especially if you're told that it might help you in certain treatments. For example, people consider giving injections in the eye, you might do better because you have some genetic type, but that hasn't been completely proven at all. I think the second thing that's been very common is to take genetic testing and then apply this to the ARVO supplement and say if you have certain genetic disposition, you should not take this ARVO supplement. We have found that this to be not true. We have done replication samples. We try to repeat the experiment. We couldn't find the same things as some of the other investigators. We feel strongly that AMD testing is not to be recommended. And there are a number of other bodies, such as the American Academy of Ophthalmology, which really is our big organization that helps us guide us with the guidelines and put out a very strong message saying that it is not useful to do that prior to treatment, but really important for research.
Dr. Chu, is there anything else you'd like to add that we should know about?
No, I think that's all for today, but I think there's plenty to chew on today. So,
thank you so much for your time, and thank you for your wonderful service.
And thank you for having me.